Welcome, everyone. On behalf of Cambridge Health Tech Institute's Global Web Symposia and our sponsor for today's event, Biomodels, I'd like to welcome you to preclinical models designed for the development of treatment strategies for a range of radiation-induced tissue toxicities. My name is Elizabeth Lamb, and I'm the host and moderator for today's event. At this time, I'd like to introduce our presenters for today. First will be Dr. Stephen T. Sonis, founder, partner, and CEO of Biomodels. Our second presenter is Dr. Maria L. Mancini, who is a principal investigator at Biomodels. And our third presenter will be Gregory D. Ling, partner and chief scientific officer at Biomodels. So with that, I'd like to welcome our first presenter, Dr. Sonis. Welcome. The presenter ball is yours.
Thank you, and thanks for everybody for joining us this morning. As you heard, we're going to talk about animal models of radiation injury and radiation toxicity this morning. What I'd like to do, though, to start off is just give you a little bit of background about Biomodels for those of you who haven't worked with us or don't know us. We're a CRO that's located just outside of Boston, and although we have a view of the Charles River, it's not quite as dramatic as the one on this picture. We were founded in 1997 as a spinoff from Brigham and Women's Hospital, and really our focus and passion is designing and implementing translational models of human disease to help our clients who vary from startups to big pharma to academics to go from concept into the clinic. And of all of the statistics that I could cite about us, the one that's most important to us and my favorite is the fact that in the course of our history, we've been successful in getting over 36 biologics, devices, or drugs from concept to patients for a wide variety of indications. Our therapeutic expertise is delineated on this slide, and as you can see, it spans from supportive cancer care indications to a variety of inflammatory diseases to some behavioral and neurological diseases. So with that introduction, let's talk about what we're going to deal with today, and that's radiation injury. And we're going to do really 5 components of this. One, I'll spend a little bit of time talking about the history and biology of radiation injury. We'll go into some specific animal models of toxicities associated with radiation-containing anti-cancer regimens. And as you know, probably 50% of patients who are treated for cancers in the United States get radiation as a component of their treatment. We'll talk about modeling toxicities in the context of anti-cancer therapy. Clearly, if one is dealing with protecting normal tissue, one of the considerations is the do no harm rule, and that is that we don't want to protect normal tissue at the cost of also protecting tumor. We'll talk a little bit about the models of radiation countermeasures, and then within the context of the overall discussion, talk about how we can use genomics to understand radiation injury and the value that brings. So when we talk about radiation injury, there are really 2 buckets that we can think of. One is radiation toxicities associated with radiation therapy, and those generally are either tissue-specific, so they're focused on the mucosa of the GI tract, the skin, the lung, or the bone marrow as examples, or they tend to be systemic. And examples of those would be radiation or cancer-associated fatigue or cognitive dysfunction. On the other hand, rather than tissue-specific toxicities, there are those that are more generalized and typically associated with total body irradiation. On the clinical side, TBI is pretty much limited to conditioning regimens associated with stem cell transplant, particularly for allotransplants for malignancies. But there's also a secondary concern, and that's the unanticipated radiation exposure that can occur with radiation leaks or dirty bombs. So we'll speak to both of those areas. From the standpoint of radiation therapy and radiation toxicities, these are not new. This is a picture of Madame Curie, who at about the time of the end of the First World War, so about 1918, 1919, really started the first use of therapeutic radiation for the treatment of tumors, as is delineated here. And it was pretty rudimentary, but if you go back and look at her publications from that very early time, you'll note that she recognized, and as did everyone who's followed since then, that there's a fair amount of collateral damage that occurs to normal tissue that's associated with destroying tumor. And so although we've come a long way in terms of how radiation is delivered in the present day, radiation toxicities or toxicities associated with radiation therapy are still very significant to providers and patients and also third-party payers, because they come with a significant cost. One of the things that I did want to mention about injuries associated with radiation therapy is that they give us an opportunity to model, in some ways, a variety of other diseases. Because these complications are iatrogenic, basically what happens is we're taking a normal subject, except for their cancer, and inducing in them a radiation challenge that starts a whole series of biological events that in many ways results in phenotypes that are translatable to other diseases. And the biology underlying these changes are very similar to the biology that we see with more chronic disease. So I've just, as an example, here in this third bullet, mentioned radiation-induced gut injury and inflammatory bowel disease. The same thing is true if one looks at fatigue or cognitive dysfunction. And what's especially interesting is if one looks at the gene attribution of those injuries, both in radiation and then in chronic disease, they're very similar. So, for example, if one looks at cognitive dysfunction, radiation-induced or chemotherapy-induced cognitive dysfunction, and evaluates the genomics underlying that change and compares that to the genes that one sees in patients with Alzheimer's, they're very similar. So it's a very radiation-induced injury associated with radiotherapy does provide us with opportunities to study other diseases as well. As far as the pathobiology goes, I think especially with tissue change, there's been a marked paradigm shift in thinking over the past decade and a half. You'll recognize in this schematic in panel 1 normal stratified squamous epithelium. This could be in the mouth, the skin, or esophagus. And you'll note, you'll remember that renewal of these cells starts in the basal epithelium. There are daughter cells that are split off. They go to the surface, and they're sloughed, and this process repeats and repeats. the historical idea regarding radiation-induced injury was that radiation, or in the case of chemotherapy, there was nonspecific injury to these basal stem cells. They were destroyed and became either necrotic or apoptotic. The renewal stopped. There was atrophy of the tissue, which then went on to develop ulceration, and then ultimately went on to heal. And this was a very straightforward and nice and neat paradigm. The problem is, if one starts to look at the kinetics of this and actually look at the numbers of cells that are involved in each of these stages, this paradigm didn't make sense. And so we went on to do a study, and this is actually the only clinical trial that I'm going to speak to today, in which we wanted to model for regimen-induced mucosal or epithelial injury. We call this experiment the orange experiment. And what we did is we brought in 200 subjects, put them in an auditorium, and then I stood at the front of the group with a basket of 12 oranges. And what I told the audience was I was going to take these oranges and randomly throw them at the audience. And I would tell them when I was going to do it, but I was also going to shut the lights out. As far as the endpoint goes, it was pretty straightforward. We figured if we were modeling for clonogenic cell injury, we would look for tissue damage, and so we were looking at black eyes within the audience. And knowing that we had 12 oranges at the podium, we predicted that we would have 12 black eyes in the audience. In fact, what we observed was 56 black eyes, and the black eye distribution was not influenced either by the proximity to the podium or the location within the room. So the question was, what could we attribute to the etiology of these additional black eyes? And in fact, what we found was that when I shut the lights out and threw the oranges into the darkened room, many of the participants reacted by bringing their arms up to protect their eyes. And their elbows indiscriminately hit the eyes of the person sitting next to them. And so there was a bystander effect, or a nonspecific effect, of my throwing the oranges to multiply the amount of injury that happened. And in fact, what we've learned is that signaling from radiated cells produces many biological injuries. There are a wide range of pathways that are activated that then impact those basal target cells. So the good news is there's, from a biological standpoint, from a scientific standpoint, there's a tremendous amount to study. But this also provides a number of opportunities for druggability. And in fact, if one looks at the canonical pathways based on changes in gene expression and the relevance to mucosal or epithelial injury, you can just get an idea of how robust the signaling that's produced is. And so the opportunities for this really are threefold. One, we can identify targets for druggability or biological interventions that target those pathways. The second is we can establish mechanisms that lead to tissue injury that correlate to other disease states, so to more chronic disease states. And the example that I mentioned before of IBD and GI toxicity is a good one. And then finally, we can link risk to genetically controlled pathways. So the diversity and complexity of the biology is actually a huge opportunity from a variety of standpoints. We've been able to create animal models of specific toxicities that is provide a conduit for drug discovery and enablement, as I mentioned before. Again, we've used those models to look at chronic disease. And importantly, genomic analyses between the animal models that get radiated and undergo toxicity and what we see in humans has been remarkably consistent. So it provides a very, very good way to validate the biology of the animal model as it translates into humans. So with that background, I'd like to move along and talk about a couple of toxicities. One that's tissue-based, and that's mucositis, oral mucositis, and the other is fatigue. So oral mucositis is probably, of all of the epithelial or tissue-based toxicities, among the best studied. As you know, it results in severe ulceration throughout the GI tract, but in the mouth results in these very, very large, penetrating, deep ulcers. So for those of you who get canker sores, for example, you know how disproportionately painful those are. Those are relatively shallow ulcers. The ulcers of mucositis actually penetrate to muscle, so they're much deeper, much more diffuse. Here you can see a pseudomembrane overlying a big ulceration on the patient's lateral border of the tongue. We've used a variety of animal models to study mucositis. This is the hamster, which has been a mainstay of what we've done, but we've used animal models to look at both acute radiation and fractionated radiation, and then combinations of chemoradiation, which is the most traditionally combination that's used clinically. And as you know, patients don't get a single blast of radiation, but they get incremental doses of radiation over extended periods of time. So one of the things that's incumbent on any animal model for measuring radiation-induced, clinically induced radiation toxicities is that not only does it look at acute radiation, but it also looks at fractionated radiation. And while we're going to talk a fair amount about the hamster model, I'd also like to point out that there are rat and murine models that we've used as well when there's a particular advantage to those species. So the hamster model involves the golden Syrian hamster. We use both acute and fractionated dosing. Typical study duration is 4 to 5 weeks. The endpoints are very typical of the endpoints that are used in clinical trials. And so one of the things that we try to do with all of our models is to have endpoints that are clinically relevant and very translatable into clinical trials rather than endpoints that are esoteric and of marginal clinical relevance. So from the hamster standpoint, the key endpoint, the key translatable endpoint is grade 3, which indicates ulceration. In patients, ulceration really is the big driver of bad outcomes. And here you can just see how analogous the ulceration output is in hamsters versus what we see in patients. Certainly the degree of ulceration or the finding of ulceration in hamsters is not a subtle finding. If we were to send you a series of images today in which you compared animals with ulceration to animals without ulceration, it would be a very binary outcome, and you would have no problem separating those two groups. So one big question is really how good are animal models? The hamster model has been around for a long time. The biological basis and sequence of chemoradiation injury in animals is very similar to humans. We've looked at gene expression in the hamster and compared that with gene expression in the humans as it correlates to the development of mucosal injury, and there's a tremendous amount of correlation. Interestingly, the oral flora, the microflora, we're all concerned about the microbiota and the microbiome. So the finding that the oral flora in hamsters is very similar to humans is a plus. Hamsters are desert animals, and so they have a degree of inherent xerostomia, which mimics what happens in humans after they get radiation therapy. If one follows the kinetics of myeloablation or myelosuppression in the bone marrow of hamsters following chemotherapy or total body irradiation, it's exactly the same as one finds in humans. The kinetics and the phenotype of injury in the hamster is very similar to humans. As I mentioned, the development of ulceration is really an unequivocal endpoint, and we can model for fractionated radiation in the hamster to mimic what happens in patients. But I guess really the proof is in the pudding, and so the use of the animal models, and particularly the hamster, has been going on long enough now so that there is data in the public domain, preclinical data, and also clinical data that demonstrates the efficacy of the model in terms of predicting in a very, very good way and close way what happens to patients after they're treated with drug. There are publications available for all of these things, and if you're interested in getting reprints or have any questions about these, please don't hesitate to let me know, and I'm happy to share those publications and citations with you. So let's move on from a tissue-based toxicity to a more generalized systemic toxicity, and that is fatigue. As you know, fatigue is a huge problem associated with treatment in cancer patients, both patients who get chemotherapy and patients who get radiation therapy. And unlike most of the tissue-based toxicities, this is a toxicity that is persistent and lasts long after patients have completed therapy. So it would be not unusual for a patient to come in 6 months, 12 months after they've completed their course of radiation. The patients look good, they're gaining weight. You ask the patient, how you're doing, and they say, I feel well except for one thing, and that is I'm chronically fatigued. And these patients have symptoms very similar to chronic fatigue syndrome. And interestingly, when you look at their gene expression in this group of patients, it tracks very well with gene expression that one sees in chronic fatigue syndrome. But you can see what the impact of fatigue is in patients' quality of life. And so this has big implications, not only from the patient standpoint, but also from employer standpoint and from third-party payers. And so we set about to establishing a model for this, which involves radiation to the abdomen. We measure patients' activity using wheel running. And what we find is that if you radiate patients, you can see what happens to their radiate animals. I'm sorry, going back and forth. I told you I was in a translational mode. Going back and forth, you can see the impact of radiation on both acute and late fatigue. So it's a very important clinical model and a huge unmet clinical need. If we look at the genomics of radiation toxicity in this model, it was one of the models in which we were able to look at differences in gene expression in animals and compare that with gene expression in patients. And the patients that we studied were patients who were being treated for prostate cancer. And in fact, the validation or the concordance of gene expression in the animal model with that seen in patients was remarkable. And so it gives us a great deal of confidence in the validity of the animal model as a way to assess mechanism of action and identify druggable targets, and also as a lead to determine who among patients who gets radiation is at risk for this toxicity. So the gene analyses that we use, and as you know, there are 4 really common types. Candidate gene studies and GWAS studies have been around for a long time. The results, frankly, with those have been disappointing. So we've focused on Bayesian networks and filtering and recursive feature elimination as innovative ways to look at gene expression in patients and animals. We use a series of filters that then identifies functional networks that, when we put everything together, lets us look at the group or the cluster of genes that then defines the toxicity. And the beauty of having this type of map is that by looking at the central cores of this, the nodes of this, it identifies areas that are good biological targets for intervention. We've been able to use this type of methodology to assist our collaborators with establishing mechanism of action, defining what, if they have a series of candidate drugs, would be the best agent for a variety of clinical indications. So with that, I'd like to turn the discussion over to my colleague, Maria Mancini, who's going to begin talking about radiation-induced dermatitis.
Okay, thank you, Dr. Sonis. So I'm just going to spend a few moments discussing another tissue-based toxicity associated with radiation therapy, and this is known as radiation dermatitis. And it's defined as injury to the skin resulting from exposure to radiation, and it's generally associated with the treatment of cutaneous neoplasms such as head and neck cancer and breast cancers. It has a high prevalence where it occurs in 85% of patients receiving radiation therapy, and it ranges in severity from mild erythema to moist desquamation and ulceration of the tissue. As you would expect, it has a large impact on a patient's quality of life, and it can be dose limiting where patients are unable to tolerate the high doses of radiation that they might require for their tumor treatment. And then this also, as Dr. Sonis mentioned previously as well, is a burden on the economic and healthcare system as patients are able to work less, requiring more time off, or having to leave the workforce completely. And here is just an example of the sort of range of doses of radiation and the effects that you might see, where at low doses of radiation, you would just see that mild erythema, hyperpigmentation of the skin, whereas at higher doses of radiation, you're going to start seeing some of the moist desquamation and ulceration of the skin. And the onset of these higher doses is a few weeks after radiation therapy, but they can persist for months or even years after treatment. At very high doses of radiation, you do start to see fibrosis of the tissue, in addition to ulceration and even telangiectasias developing 6 months to a year after radiation therapy. So in order to address this clinical unmet need, because there really aren't any treatments available to address the mechanisms of radiation dermatitis beyond treatments that are utilized in thermal burns that you might see. So we did generate a model to help to try and enable some compounds that might be efficacious in this area. And to do that, we essentially just removed the hair from the back of some wild-type animals, just using a regular electric shaver, anesthetized the animals, and then essentially isolated the skin, the shaved skin, and covered the rest of the animal with a lead shield, and just specifically irradiated that small area of shaved skin on the mice. So mice were irradiated using an X-ray source that we have here, and we can measure the delivered dose of radiation and confirm that using thermoluminescent dosimeters. And I'll talk a little bit more about that dosimetry actually later in the presentation. So as Dr. Sonis mentioned as well, it's important to have an acute model and a fractionated model to study these radiation toxicities. And in the acute model, the animals are exposed to 30 gray of radiation. This is a shorter duration model than the fractionated model. It provides a great model for screening, initial screening compounds. And here, the animals are exposed to 30 gray of irradiation, and they're scored. The dermatitis severity is scored every 2 days, beginning 4 days after exposure for 30 days. And I'll explain a little bit more the clinical scoring scale in this model. In the fractionated model, we have developed sort of a dose response curve here, and I'll show you a little bit of that data, where the onset is delayed a little bit. So you start to score severity about a week after radiation exposure, and this lasts a little bit longer than in the acute model. And disease severity is scored based on a clinical scale which covers the full spectrum of severity that was sort of described in the table in my first slide. This represents the scoring scales, as I mentioned, used in the clinic, and similar to the oral mucositis model, a meaningful signal is defined as essentially improving, reducing the kinetics and severity of disease onset, and also reducing the number of days with high scores or days of ulceration that you might see in this model. So here you see again, a mild erythema would be about a score of 1, and then you do start to see ulceration in scores of 3 and 4, and this is very closely translatable to what you might see in the clinic. And here are just some examples of the data from these models. So in the acute model, the onset is quite rapid, and with a dose of 30 gray of radiation, the severity peaks around 3, which is just at the point of ulceration, and then does resolve over the next 10 days. And whereas in the fractionated model, the onset is a little bit delayed, as I mentioned, and you see with a high dose, cumulative dose of 6 fractions of radiation, you see most of the, if not all of the animals do develop ulcers, and this resolves a bit more gradually than receiving a lower dose of radiation. And so this really does provide, this dose response curve does provide the ability to determine how severe a dose you'd like to sort of use for screening purposes and kind of set that threshold that you'd like to, sort of try and overcome. And what we do see is that the images seen in the clinical scoring and the clinical scores themselves are very, can also be evaluated histologically. And that what we do see clinically is very compatible with what we see histologically, where you can see here sort of inflammation of the epithelial layers. You see at higher doses of radiation exposure, you see actually necrosis of the hair follicles. You see immune cells sort of coming into the area, and essentially degradation of epithelial architecture. And this is very closely showing you what you might see in the clinical images. So to summarize briefly, there's really nothing available in the clinic currently to treat radiation dermatitis, so there is a big therapeutic opportunity in this area. An advantage to using an animal model is you can use topical drug formulations to demonstrate efficacy, and this does minimize some of the effects associated with systemic dosing. And the use of dosimetry, the TLDs, does provide you the ability to determine that the topical formulations don't interfere with or attenuate the delivered dose of radiation to the skin or the underlying tissue, and we can represent the disease progression using images as well as histological endpoints. So with that, I'm going to turn the presentation over to my colleague, Dr. Ling, and he'll be talking a little bit more about some additional tissue-based toxicities.
Thank you, Maria. So moving on from radiation dermatitis, we are going to begin to speak a little bit about radiation-induced proctitis. So while the mechanisms for all of these diseases as such are very similar and overlapping, the manifestation and kind of the regional kind of severity is differing, obviously. So radiation-induced proctitis is a common complication that's associated with radiation therapy for patients undergoing colorectal cancer treatment, prostate cancer treatment, or even cervical malignancy. The incidence is actually quite high in that over 75% of patients receiving targeted radiation therapy develop some extent of proctitis. And this actually results in about 400,000 new cases annually. Given that this disease can present in two different phases, both an acute and a chronic phase, that results in a very large patient population that could use to be treated. And as I mentioned, the disease onset typically occurs within the first 2 to 3 weeks in the acute phase, but the chronic phases can last months to years. And the most common symptoms with this are rectal bleeding, diarrhea, and mucosy discharge. But more long-term, you look at fibrosis, ischemic tissue, and necrosis of the bowel. And some of these indications or some of these areas may actually be required to have surgical removal, which can obviously result in other side effects and long-term damage. Typically, the diagnosis of proctitis is done via colonoscopy. This is more or less just to say that yes, it is proctitis and isn't some other sort of underlying pathology such as IBD. So as I mentioned, given the large patient population that's out there, it's interesting to note that there's a very limited number of compounds in the pipeline for this. So currently, most of the treatment strategies are directly taken from that, which is used to treat IBD patients. And while there are some similarities in the mechanisms at play, the treatments are not all that effective. So the use of the 5-ASAs and steroids work to mitigate some of the symptoms, but are certainly not curative in any sense of the imagination. In other ways to kind of limit the symptomology is to use therapeutic interventions such as coagulation to basically limit the amount of bleeding that's occurring. So in order to evaluate new therapies for proctitis, we've developed a couple different models of radiation-induced proctitis in the rat. Again, these models follow the same kind of template as the dermatitis and mucositis models that you've already heard about, using both acute phase radiation and using fractionated radiation induction paradigms. In the acute phase, we focus on a single dose of radiation of approximately 20 gray, and you can see some images here that show the kind of the presentation of the disease. One of the important aspects for us when looking at any animal model is to find a translational endpoint. So what we've used, instead of relying upon histopathology in these models, is we use video endoscopies. So we're actually performing endoscopy and colonoscopy on animals in the same manner that would be done in patients. And we can follow the disease course and as well as look for therapeutic intervention and basically therapeutic efficacy. And as you'll note, this magnitude of proctitis can be modified very similarly to that of the dermatitis with escalating doses of radiation. So in the fractionated models, we use 8 different fractions, but starting at cumulative doses of 32 gray and moving up to cumulative doses of 48 gray. You can see there's a pretty large difference in how the disease presents, going from very superficial sloughing of the tissue and underlying inflammation to very frank ulceration of the tissue. And again, looking at the time course, it's very similar in the fact that the acute phase is about a 10-day study, whereas when we get into the fractionated radiation models, we look at much longer-term effects and can follow these animals out for up to a month. And on the right-hand side here, we're just looking at the similarity similarities in how the disease presents in rodents versus humans, again, focusing on the translational aspects of the model. Kind of moving out of the gut and oral tissues, we now are going to talk a little bit about another side effect of radiation therapy, that of radiation-induced lung fibrosis. Since there are a number of patients that undergo radiation to the thoracic region to treat lung cancer, this is a common occurrence as well. Interestingly, though, the incidence is not too well documented. Often, I think, due to the fact that the patients that present with this can actually be subacute and asymptomatic in many cases. So the estimation is that it's somewhere between 5 and 40%. I think 40% being on the high side and 5 probably being a gross underestimation of the number of patients that would be subjected to these side effects. This is interesting in the fact that it's much more delayed than some of the other tissue toxicities that we see. So typically, pneumonitis is kind of the basic stage of this. It occurs in the kind of the quickest fashion, which is typically 1 to 3 months following completion of radiation therapy. So again, well out beyond the typical timelines that we see. And then for the fibrosis, most patients that do develop pneumonitis will eventually develop some sort of fibrosis, the extent of which can vary pretty dramatically. But these effects are seen much more long term, beginning at six months post therapy. And continuing out to 24 months. But once the fibrosis is there, essentially it's a progressive disease and is going to basically continue to become worse over time. In the acute phase, pneumonitis, some of the common symptoms are dyspnea, dry cough, and fever. As you move into the fibrosis, you become essentially dealing with chronic pulmonary insufficiency. And this is, again, diagnosed via chest X-ray, as we see here on the right, CT or spirometry, looking at pulmonary function. And this pulmonary function in terms of looking at how quality of life is impacted is probably one of the most relevant measures that could be used. So again here, what we've done is try to model this disease in animals. And we focused on using a single dose of radiation in this model in terms of our development, just to kind of try to keep the animal model as short as possible. What we've looked at here, and as Dr. Sonis talked about earlier, is wheel running as a measure of spontaneous activity and general health of the animals, as well as looking at lung mechanics to mimic what is done in patients. And to do that, what we use is a system called a flux event, which is basically a system where you tracheotomize the animals. You can apply a known volume of air into the lungs and look at the resistance and the changes in the lung as disease develops. We'll start with looking at some of the wheel running data in animals that have been exposed to a thoracic radiation dose. The orange line on the bottom here are animals that underwent irradiation, and the blue are animals that did not undergo irradiation, so the comparator controls. As you can see, these animals, to begin with, run a lot. So we are looking at a distance traveled of about 8 kilometers per day to start, so very active mice. Following radiation, what you see is obviously a very dramatic drop-off in spontaneous activity that persists out through 3 to 4 months. So essentially what you're seeing is that while there's a pretty acute effect here that is likely most similar to pneumonitis, you are also seeing a chronic effect in the disease. And as I mentioned, looking at the lung function, we feel is one of the more clinically relevant approaches for assessing therapies in this model. And here, these charts are basically looking at pressure-volume loop curves. So for the amount of air pressed into the lung, the pressure that's pushed back. So what we're seeing here in the black lines are the naive animals. These are the control animals that were not irradiated, whereas the red lines are animals that underwent irradiation. As we go through time, you look a month post-radiation, you can see very little changes in lung function. Essentially, the animals that underwent irradiation are identical to those naive. But as we continue this experiment out and look at 8 weeks, and even as more dramatically as we get into 12 and 16 weeks post-irradiation, there are obvious changes in very order of magnitude type changes in lung function and lung elastance. And similarly, when we look at models of other models of IPF, so idiopathic pulmonary fibrosis like bleomycin, the extent of changes that we're seeing here in week 12 and week 16 are actually very similar to the mechanical changes that you see in a model of bleomycin-induced pulmonary fibrosis. So a very clinically relevant change in lung function. Interestingly, what we were interested in looking at is in the study is twofold, both activity and lung function. But we kind of thought at the beginning that there may be some interaction between these two things. So we also looked at the difference between sedentary animals and animals that have the option of running. One of the big things that we noticed here is that the runners were actually much more healthy than the animals that were not sedentary. So the changes that we noticed in animals that had been active were much smaller than the changes in the animals that we saw that were sedentary. So note to self, keep running. Moving on from that, we're going to talk about more of a systemic toxicity, and that of graft versus host disease. And this is a very common side effect of hematopoietic stem cell transplant. And up to 80% of people undergoing this will develop some sort of GVH, and a very large portion of those will develop chronic disease. And then again, this is similar to what the other models we've looked at. This model and this disease actually encompasses many tissues. So skin, as we can see here, oral mucosa, the GI, the lungs. And this is all based on antigen-specific T cells that are originating in the graft that's administered to the donors. So to model this, what we've developed is a couple different animal models here. The first model is a mouse model that's based on the transplant of bone marrow into an MHC mismatched host. So essentially what we're looking at is C57 and BALB-C, so isolating bone marrow and splenocytes from C57s, injecting them into BALB-C mice. The mice are given a lethal dose of total body irradiation using our X-ray system, and then are essentially rescued with the bone marrow transplant. And this will develop into GVH approximately 2 to 3 weeks post-transplant. The GVH is evaluated in a very similar way that it is done in patients, and you're looking at changes in weight loss, general animal activity, their posture, fur texture, and skin integrity. And we can see in some of these images here, you go from a very healthy-looking mouse to animals that become very scruffy to animals with obvious changes in the skin over time. One of the good things about these models is that essentially we can modulate disease severity very accurately based on the number of T cells that we're transferring in. That's based on the number of splenocytes. So with increasing populations of splenocytes, increasing levels of GVH. We've also validated some positive control therapies in this model. Tacrolimus, which is used clinically. While it doesn't affect the actual symptomology of GVH, it does greatly affect mortality associated with GVH. So essentially we get 95% survival in animals that were treated with tacrolimus, whereby similar animals that were untreated, you're seeing about 50% mortality 2 months post-transplant. To kind of further these models, we've also looked at humanizing the GVH models, which would allow us to selectively target human cytokines and cells. So for these models, what we're actually using are PBMCs from human donors. In the first study we looked at was a simple kind of dose response, donor response. And to do this, what we take is a not-skid gamma mouse, so essentially a very immune-compromised mouse, also subjected to TBI to completely ablate, and then take human PBMCs and look for basically humanized GVH. So in this experiment, we characterized 3 different donors, isolated the PBMCs from their blood, and looked at 2 different levels. And interestingly, what you can see here is that based on the number of PBMCs that you inject, you can modulate disease severity pretty dramatically. The further on the left here, more severe, earlier mortality, whereas the ones that extend to the right-hand side of the curve here had more mild GVH that persisted for a month or so post-transfer. And what this will allow us to do actually is modulate the level of severity of GVH to mock or to mimic an animal that has very severe disease versus one that is maybe slightly easier to modulate in more of a subchronic setting. Again, as with the GVH scores, we see those same changes in survival. Increasing doses of PBMCs, depending on the donor, result in basically accelerated mortality. Donor 3, as we can see here in the blue, had essentially cells that were slightly more active than a couple of the other donors. But what's nice about this is you can continue to get the PBMCs from these donors over the course of time. So once you've established this, essentially we can get PBMCs from the same donors moving forward. So we'll already know where that dose response falls. So in summary, these models basically track human disease pretty closely. We can manipulate them based on the number of T cells that we're engrafting, and it does respond to positive control therapies. And with that, I'm going to hand this back over to Dr. Mancini, who will continue to talk a little bit more on the oncology side.
Okay, so now we're going to discuss a little bit therapies designed to treat regimen toxicities associated with radiation, how it's important to test them in primary tumor models to ensure that they don't impact tumor growth. So just a few points about this is the tumor model that is going to be utilized for this purpose should be designed to replicate the clinical treatment paradigm as closely as possible. The toxicity can be evaluated either in the tumor model or itself, so you can measure tumor kill in addition to toxicity, or it can be assessed in parallel with the tumor model, but as a separate standalone toxicity model, many of which we have outlined today. The compounds should be tested in the absence of radiation therapy as well in tumor models to demonstrate that there are no positive effects on tumor growth. And conversely, anti-tumor compounds should be tested in toxicity models to see if they exacerbate disease severity. So what I'd like to do is just show a few examples of some of our oncology models where radiation is used as a part of or all of the standard of care, and how these models can be utilized to also study the radiation toxicity. And so the first example is an orthotopic model of breast cancer. And in this case, human or mouse breast cancer cells are implanted directly into the mammary fat pad of a nude or wild-type mouse. Tumor growth is monitored using a digital caliper, and we also have IVUS imaging capabilities if there are bioluminescent cancer cell lines available. And after 7 to 10 days, in general, for most of these breast cancer cell lines, animals can be randomized into treatment groups based on these tumor volumes or IVUS total flux values, and then treated with fractionated radiation with or without concomitant chemotherapy, focused to the tumor, and then tumor progression is assessed. And so this model here can be used in combination with novel compounds, either for anti-cancer treatment or to address the toxicities. And I hope you can see this data here, but essentially what we've done is we've modeled different cumulative doses of fractionated radiation directed at a syngeneic breast cancer in a biopsy mouse. And what you can see here is that at higher doses of cumulative fractionated radiation doses, you do sort of cause a slight inhibition of tumor growth, but really what this graph here shows is when you do combine the radiation with chemotherapy, you do see sort of the best therapeutic signal. So the thing that I want to point out is, in addition to showing this efficacy tumor model, this can be paired with the model of radiation dermatitis that I outlined previously. So the irradiated area can be simultaneously scored for dermatitis severity in addition to monitoring tumor growth and tumor progression. And in addition, anti-tumor compounds can be simultaneously assessed for exacerbating that radiation dermatitis that might develop. Alternatively, therapeutics designed for radiation dermatitis can be used in this model to determine that these compounds don't affect tumor growth. Another example is a model of head and neck cancer. Head and neck cancer is increasing in prevalence as the HPV population is increasing. And the standard of care for head and neck cancer is cisplatin followed by fractions of radiation commonly, and that's known to induce toxicities that we've described earlier, and including oral mucositis. So in this model, orthotopic model of head and neck cancer, human head and neck cancer cells are implanted directly into the tongue. After about 21 days, animals can be randomized into treatment groups. We do have a few bioluminescent cell lines here in-house that we can use. Alternatively, the tongues can just be visualized for the presence of tumors. So in this experiment, animals are treated with a single dose of cisplatin in combination with fractionated radiation, focused directly to the tongue, and tumor progression is assessed. And you can see here that the combination of radiation and chemotherapy does reduce the tumor growth in this model, and this is represented here by actual IVUS images from the study. And the associated standard of care model for this indication would be the oral mucositis model. And as Dr. Sonis alluded to, we do also run this model in rats and mice. So in this case, tongues can be assessed for both reduction in tumor growth as well as severity of oral mucositis using a scoring scale that we've developed similar to that used in the hamster model. And the mucositis severity and tumor progression in this model can be assessed in the same study, so that's quite useful. And just as an example, using an acute dose of radiation, for example, you can induce oral mucositis in the mouse tongue, and it tracks very similarly to what we see in the hamster. And then the last example that I'm going to show, while there are many others, just to highlight a few here, an orthotopic model of glioblastoma that we've developed where GL261, which are mouse cells derived from a C57 mouse, are directly implanted into the brain. After a few days, the cell line grows very quickly. Animals are randomized into treatment groups similarly as the other models, and then subjected to focused radiation to the tumor, and basically tumor reduction and recurrence is assessed. And with this model, you can also assess fatigue and neurological toxicities, as Dr. Sonis outlined, fatigue as one of them. Also, neuromuscular endpoints such as use of rotor-rod and other behavioral endpoints can also be simultaneously assessed. So I'm just going to wrap up here in the last couple of minutes to discuss radiation countermeasures models that we've developed in recent years. And just to give a very brief background of acute radiation syndrome, which is a syndrome that develops as a result of exposure to penetrating radiation, a lot of times in the context of terrorism or a nuclear accident. So there are three classic areas of ARS: bone marrow syndrome, gastrointestinal syndrome, and cardiovascular CNS syndrome. So bone marrow syndrome in humans occurs as a result of very low doses of radiation, 2.5 to 5 gray. Symptoms include anorexia, nausea, and vomiting, and death of stem cells in the bone marrow. Gastrointestinal syndrome occurs at higher doses of radiation. While the symptoms are very similar, the patients from this syndrome will actually usually die within 2 weeks of exposure, and the cause of death is different from bone marrow syndrome, where the cause of death for GI ARS is typically infection, dehydration, and electrolyte imbalance due to damage of the GI tract as opposed to the bone marrow. And then cardiovascular CNS syndrome, this results from very high doses of radiation, and all those exposed are expected to die within a few days. So in an attempt to model the bone marrow toxicity in GI ARS, we've developed a couple of animal models that I'd like to briefly go over with you all. And just to sort of set the stage, we use X-ray radiation source, and we've discussed this in all of our models today. And in the total body irradiation model to study the bone marrow toxicity, mice are exposed to doses ranging from 6 to 10 gray. This is strain dependent. There are definitely differences in mouse strain sensitivity to total body irradiation. The mice are placed in this PI restrainer, and then they're radiated in the X-ray, and the dose here can be confirmed using an ion chamber dosimeter that can be put right in the X-ray with the PI chamber. In this model, weight loss and mortality are observed beginning around day 10 and continue for about 7 to 10 days thereafter. And in this particular data set, the C3H mice, which are very commonly used in this field, they're very highly sensitive to total body irradiation. And you can see here we've established dose-response survival curves in doses ranging from 6 to 7.5 gray in essentially 0.25 gray intervals, because they are very sensitive to the total body irradiation. And what you'd like to do is achieve LD20, LD50, and LD80 levels to screen compounds for efficacy in this model. And the CD2F1 mice are another strain that are used commonly in this model. These are less sensitive to TBI, so it's similar where you can induce a dose response, but using this strain of mice, you're looking at doses ranging from 8 to 10 gray and half gray dose intervals to achieve those same LD20, 50, and 80 levels. And finally, I just would like to mention a model of GIARF, so total body irradiation, where you're actually protecting the long bone so that you can expose mice to higher doses of radiation, protect that bone marrow, and really focus on gut toxicity. So mice are placed in custom restrainers here where the left hind limb is shielded to protect the bone marrow. A single dose of radiation is administered, and animals are placed in a rotating turntable to ensure uniformity of exposure. And because the mice are on this rotating table, the ion chamber dosimeter cannot be used. So the individual TLDs that we mentioned previously are placed on the turntable to confirm the delivered dose. And just wanted to show an example of these very small dosimeters that are placed in the X-ray, and they can be read, and the dose confirmed for this model. And in this model, doses between 12 and 15 gray, so much higher, are administered, and weight loss and mortality are observed beginning as early as 4 days after irradiation and continues about a week thereafter. And so just an example of dose responses here that you might expect in this model, anywhere from 12 to 14 gray will produce the LD20, 50, and 80 that we mentioned previously. And my final slide is just to show additional endpoints to survival that can be used and weight loss that can be used in this model, where you can actually measure the levels of plasma citrulline by ELISA as a biomarker for toxicity. And so you can see here that as the damage as the radiation dose increases, the levels of plasma citrulline decrease and actually do not recover in higher doses associated with a lot of lethality. And also histological endpoints can be paired with this model to look at the damage to the gut, which does appear as early as 4 days after exposure to radiation. But both TBI models do provide highly translational results for testing therapeutics for radiation toxicity mitigation. And so to summarize today, we just want to make the point that it's not possible to segregate supportive care from tumor therapy. So we do feel very strongly that both types of models need to be utilized. The problem of radiation toxicity is complex. Due to new therapeutic strategies being developed all the time, more toxicities are emerging, so we are playing catch-up. Toxicities are tolerated by oncologists, but not as much by patients until the patients stop showing up for treatment. And finally, many of these toxicities that we mentioned today do share a common etiology, and therefore it can be expected that a treatment that works in one indication will often work in another. And so this does open up the possibility for systemic therapy strategies instead of individually targeting one indication at a time. And with that, we'd just like to leave here our contact information. Should you have any further questions about anything that you've heard today, or would like any additional publication materials or a copy of this presentation. And I guess we probably don't have time for questions. So.
Thank you very much, Dr. Mancini. No, I fear we've run out of time. However, I have taken note of all of the questions, and I'll be forwarding those on to our presenters. So with that, I'd like to thank Dr. Sonis, Dr. Ling, and Dr. Mancini for their wonderful presentations. I'd like to thank Biomodels for sponsoring today's event. And most of all, I'd like to thank all of you who came and spent some time with us. And I hope you got some information that will make your jobs a bit easier. Thank you so much. Bye-bye.